With that, Elizabeth, I'd like to introduce you. Go ahead.
Excellent. Thank you, Lisa. As Lisa mentioned, I'm going to present some basics about nitrous, but not spend a whole lot of time on that aspect of it. Rather, I'm going to sort of walk you through the journey that Monadnock Community Hospital went through. We were one of the first hospitals, inpatient hospitals, in the country to implement it. Not the first, but one of the first, and we were the first in New Hampshire. So we have done a lot of sharing information with people in both ways. We're eager to know what's working and not working in other hospitals. So, and with that, we'll just get started. Hopefully. Okay. So this is, again, just a brief overview of what nitrous oxide is. It is two nitrogen atoms and an oxygen. It is colorless and mostly tasteless. Some of the patients report kind of a sweet taste to it, but it's not a strong odor at all. It's stored in e-cylinders for us here. I know some people have it, who are lucky enough, have it in their walls, but it is a liquid that's in, similar to an oxygen tank, but it's a smaller e-cylinder. The nitrous is administered with a 50% blend of oxygen. At this blend, at a 50-50 blend, it is not considered anesthesia, and you'll hear me say that a couple times throughout this webinar, because I think that because it's a gas, a lot of people do feel like it falls under anesthesia, and with that comes a whole lot of other protocol and procedure. So if you just start knowing from the very beginning that this is not considered anesthesia at this blend, it does simplify things a bit. Nitrous can be given through mask or face mask or mouthpiece. We really do prefer to use the mask. The patient holds the mask to our own face and will inhale and exhale into the mouthpiece or mask. And we have found that most patients, while they have no problem inhaling through the mouthpiece, they do tend to pull it away from their mouth and exhale into the room, which we'll talk about a little bit later. But for scavenging purposes, it is, I think, a little easier for the patients to use a mask. But the mouthpiece is available if somebody had any claustrophobia or any other reason why they didn't want to use a mask. One of the things that I think is important when people are asking what is nitrous, it's easy for people to say, well, it's the same as laughing gas, or you might hear people refer to it as laughing gas. And I think it's important, we don't use that term here intentionally. We feel like it sets an expectation for the patient that's not realistic. At this blend, we've never had anybody having, while they may have some euphoria, nobody is hysterically laughing. Typically, they're in pretty active labor, which is would be an unusual thing to happen, anyways. But and I think that it's also important to, when you're setting the expectations, that this is not going to take all of their pain away. They are still going to remember what's happening. And again, at this blend, it's not intended to act like anesthesia. All right, moving on to, so the history, the U.S. is actually a little behind. Nitrous was used in the U.S. It fell out of favor when epidural started to really become a lot more popular. Nitrous is used by about 95% of the dentists throughout our country, and they can go up to a blended amount of 70% nitrous, which is more than what we are using with Pro-Nox. Certainly, the rest of the world has gotten this right for a long time. The Canada and the UK are using it. Up to 60 to 80% of their patients are utilizing nitrous. Doesn't mean necessarily that they're using it only using nitrous, but that this has been around for a long time. This is not new medicine. It's just as being sort of introduced in the US. So moving on to what nitrous does. It is somewhat of an unknown action. We know that it releases endorphins and dopamine. There's still work being done on totally understanding how it works. We know the effect it has is that patients are reporting sort of this disassociation with their pain. So they are still experiencing pain, but it's changing their perception of their pain. So we've had patients say, yeah, I knew I was having a contraction. I just didn't seem to care. Like I was sort of, observing it from afar, which is, that's terrific. But it does not work like an epidural. It is not a complete sensory block. And clearly, if there's a disassociation from pain, we are seeing that there's also a decrease in anxiety. It's been compared to the sort of adrenaline that runners experience. Myself, I can't quite speak to that, but some people have compared it to what it feels like when you have a runner's high. We know that nitrous moves through the tissues in the human body very quickly. So it has a very rapid onset, and it also has a very rapid, offset, if you will. It's very quickly clearing, so if a patient isn't liking how it's making them feel, luckily they can just take a few big, deep breaths of room air, and they're not feeling the side effects. So to that point of side effects, probably the biggest we see, and you can see I put the percentages, they're listed in order of the most common. So some sleepiness, nausea, feeling lightheaded or a little dizzy. And some women will say they just don't feel right with it. That is less, we see that less in our population. Nausea, we have yet to have a patient who has had nausea that was so bad that it needed to be treated, although I know that there are some other hospitals that will order Zofran with the nitrous at the same time, but we haven't had to do that yet. It is dose dependent, if you will, so the more that a patient, the deeper the inhalation is, the deeper breath she takes, the more medicine she will potentially feel the side effects more acutely. So if we have somebody who's feeling a little bit of nausea or feeling a little bit too sleepy or lightheaded for her own liking, we'll tell her to just take either less frequent breaths of it or to breathe a little in a more shallow way. And typically that does it. We don't normally have to treat her symptoms. So who can use it? Basically anyone but the people listed below. So in our practice, so just to set a little context, we've been using nitrous since October of 2014. And we have yet to have anybody who was ruled out of using nitrous for any reason other than already having narcotics on board. So we'll talk about that in a minute, but the hypersensitivity or allergy, we have not seen any of these. Again, with the exception of somebody coming in who was using street drugs. So B12 deficiency is the one that most people point to. This needs to be a sort of a documented deficiency, and if they are receiving treatment for the deficiency, then they would be eligible to use nitrous. But again, we aren't typically running B12s on pregnant women, so this would have to be somebody who already understood that this was, that we're not in a therapeutic level. Let me just go back here. So requirements for greater than 50% oxygen is the last bullet. So if we had somebody, certainly if you were in a situation where you needed to deliver O2 to a mom at greater than 50%, she would not be using nitrous at the same time. So what about babies? So we have a lot of questions about how does this impact fetal monitoring? Do you see a change in the fetal heart rate? And I'm happy to tell you that we do not. Probably if you have administered narcotics to a laboring woman, you've seen the effects. You can see the effects on the fetal heart tracing. The baby will get, we will say the term nubanized, or, you can get a little bit less variability. Baby can get a little sleepy looking on the monitor, and we're not seeing that at all. You could not look at a fetal monitoring strip and know when nitrous was or wasn't being utilized. So it also doesn't necessitate additional monitoring. So if the patient does not have an order for continuous fetal monitoring, the use of nitrous does not put her in that category. So you would continue to do whatever fetal monitoring was appropriate for that level of her labor experience. There is no impact on APGARs. We know that the nitrous does cross the placenta. There is blood levels of about 80% of what the mother's level has been found in the baby, but the first couple breaths after delivery, the baby's clearing it as quickly as the mother would clear it, and you could argue probably faster because it actually doesn't have the same blood level. There have been some studies, and that's what this last bullet here is. There's some studies that nitrous has caused apoptosis in neonatal rat brains. This was, some people have had there's a hard time with this study because the nitrous was not blended and the rats were exposed to a much longer length, so a continuous length of nitrous. So it wasn't intermittent use. So there's certainly, if you do enough reading about nitrous, you'll see this study shows up. We haven't done enough in recent years to sort of be able to have that study drop off, but it's there. So other things to consider regarding the baby, I think I've already said this. The newborn, the first couple of breaths of a newborn would clear any nitrous that the mother may have been using. Typically, we're finding women are not using it in those last final pushes. We do have one OB who prefers that the mom stop using it just as she's crowning. Other OBs don't mind her using it all the way through. So again, we've never seen a depressed baby, never seen a change in APGARs that was related to nitrous. So why use it? So nitrous, as I've mentioned, it's a very effective pain management option that breaks through this fear, pain, tension cycle that can be pretty common in laboring moms. If you've ever heard of Dr. Dick Reed, he's a theorist and physician that did a lot of work relating to moms' labor becoming less functional because of the amount of fear, pain, and tension that she's feeling. So nitrous and the disassociation of pain that nitrous gives the mom will help break this cycle. So we've had people, and there's a YouTube, Lisa might be able to share with this group if you're interested, but we had a patient do a YouTube interview for us, and she talks about just using it. Her intention was to have an unmedicated delivery, and she, I think, feels like she somewhat achieved that. And she talks about using nitrous to just sort of reset her. So when she was feeling like she was getting out of control, she would use nitrous for a few contractions, and then once she was feeling a little bit more calmed down, she would stop using it. So because it's patient controlled, that's a clear benefit for the women who really want to be able to sort of titrate their intervention, if you will. What you're looking at here is an ad. I'm sorry, the quality's not great. This was an ad that our hospital ran. This was one of our first patients who used nitrous in her baby. So some of the advantages are you can initiate nitrous at any point in the labor. We have found that women are getting it started, they're initiating it, and then knowing how it makes them feel, they'll use it for a little bit, and then they may decide that, you know, I'm not feeling like I need to use this now, so it'll stay in the room, we'll hang the mask up, and then when and if they feel like they need it again, they can have it. Some women, you couldn't pry the mask out of their hand. So once they get it, they're holding on to it throughout the rest of their labor, which is also totally fine. We haven't seen any evidence, there's no evidence that supports that it slows the contractions or the labor down. Probably to the contrary, these women are not bedbound, so they're able to get up, they're on the ball. Once we have a better sense of how they're feeling, we will let them get up on a ball with some staff around, of course, or a support person. We've got women using this in the tubs with great effect. We haven't seen any impairment or ability to push in pushing efforts. Women will a lot of times use it in between pushing, and then when it's time to push, they'll put the mask down, but no decreased sensation, just helping them get through sort of the intensity of that stage of labor. Our policy does not require IV access. There is no medical indication for that. There's no rescue med that you would be administering through an IV. So we're not requiring IV access. I think this is a hot topic for some hospitals, and we can talk about this a little bit more at the end, but I think there is a school of thought that every laboring woman should have an IV, and if that's sort of the culture or the process or protocol at the hospital, then that's sort of totally aside from nitrous. The use of nitrous does not necessitate IV access. And I think that's important to remember. There's no changes in maternal circulation with nitrous, so we don't see any hypotension, and consequently, we're not seeing any fetal distress related to that. The Pro-Nox machine is really fast to set up. So we are a small community hospital. We do not have 24/7 anesthesia in-house unless it's indicated for another reason. So if somebody comes in and is active and looking for pain management quickly, the nurses are able to set this up within minutes. As I already mentioned, we do not need any increased fetal surveillance. We don't see any impact on the fetal heart rate or on APGARs. I think I've already talked about this. And because of its rapid off, if you will, first couple breaths, and we're seeing it clear. So as far as patient education goes, it is addressed. Nitrous is introduced to our patients in the office. They will talk about it with every patient. We have written information that we provide to them in our childbirth education classes, certainly on admission. If they haven't already been if they haven't already discussed this with their docs, then we would introduce them to it. We've got a consent that needs to be signed. The consent is really one of those things that we could talk about more at the end, but it is, we don't consent to give somebody Nuvain. We don't consent to give them, any other pain medicine other than an epidural. I think that the push to consent these patients really came from addressing the fact that nobody else in the room can touch the mask. Diversion is something that I get asked about a lot. I'm sure Lisa can say, how do you make sure nobody else in the room uses it? And, not to be, laissez-faire about it, but there's some level of, well, even if somebody did take the mask and take an inhalation of it, they're not going to they couldn't even get to their car without it being cleared. So as far as we know, we've never had any diversion. The nitrous machines are locked up when they're not in the patient's room in use. But the consent really clearly outlines what our expectation is. If there is any diversion, that we're suspecting, then that would be addressed, and the patient would have to choose whether the nitrous leaves the room or her partner, who could be diverting, leaves the room. So I'm happy to answer any other questions about that if we get to them at the end. So we do talk to the patients about potential side effects, what would make them not a candidate to use it. Our patients who really desire lower intervention births really are excited about this offering, because it doesn't mean that because they chose it, they're now going to be bedbound or stuck on the monitor, unless it's clinically indicated for a different reason.
Hey, Liz.
Yep.
We've got a question that came in that asked if you would share your consent form. And I have an old copy, unless it's changed. Would you mind if we share your consent form?
No problem. I don't think it's changed. It hasn't changed anytime recently, so I'm happy to for that to be shared. Sure.
Wonderful, wonderful, wonderful. And we have one more question while we're on this topic. Do you have a specific amount of time that you have the patient stay in the bed before you allow her to get up once she started the nitrous?
Yeah, it's a good question. So sometimes nitrous is initiated not in bed. So we will have them in a chair, or wherever they are is where they need to stay for at least about 15 minutes. Now that's if they only take one inhalation of nitrous in 15 minutes, then we wouldn't say, oh, okay, your 15 minutes is up, so now you can move about. We really want a good sense of how they're faring with it before we let them get up and move around. We have not had a situation where nobody's fallen ever. And we haven't had a situation where we felt like, wow, this person really should not be up and moving around. She's really unsteady on her feet. Typically, patients are pretty self-limiting. So if they're feeling a little wobbly, then, they're the ones who are like, well, I think I'll go from the tub to the chair, from the chair to the ball, from the ball to the stool. So, with our support in the room, typically, like I said, 15 minutes is about what we'll say. But if you haven't gotten a good sense of how the patient's responding to it, then we would wait a little bit longer.
Excellent. Excellent. Thank you. Everybody keep the questions coming. So how those questions came into me through your chat window, you can send me a message and then I'll ask it of Elizabeth for you. Go ahead.
Okay, thanks. So the last thing I want to talk about on this slide is that it's really important that patients know that they're not committed. I think that we probably have experienced this if anyone's bedside nursing, where a patient feels sort of tortured by their decision to get an epidural sometimes because they feel like, well, what if I don't like it? And what if it slows my labor down? Or what if there's a lot of things that, now, yes, you could stop the drip. You could, there are things there. It's not impossible to undo an epidural, but I personally have never had anyone who's said, okay, never mind, I'll take the pain back. So I think that nitrous is nice because patients can feel like, well, it's new. I may not have a lot of friends who have had experiences with this, so I'll do it. I'll try it. But if I don't like it, can I move on to something different? And we feel like that's a really important part of their education. Absolutely, 100%, they can move on to an epidural. We refer to it as converting to an epidural. They can move on to narcotic use. Or just stop using it. And I'm happy to share my policy. My policy actually, it does outline when can they move on to something else. We've had patients who, if they're really feeling out of control, we will actually have them using nitrous while they're getting their epidural placed. And again, with the anesthesiologist in the room, without getting too much into the details of that, we do have, like, when does one begin and the other end? So we'll address that. I'll talk more about that later. So logistics, sort of the how-to. So we evaluate the patient for eligibility. We get the consent. The nurses are allowed to consent the patient. hopefully the doc has already spoken to them about it, but we at this hospital are allowing our nurses to provide and document the education and obtain the consent from the patient. We will educate the patient and everyone in the room. We feel like it's important that this education not be provided when dad goes out to the car to get the bags. We really want everybody to understand what it is and what our expectations are. The equipment is set up very quickly, and again, I already answered this, but the nurse and or the doc will stay in the room with the patient for at least 15 minutes and or until we feel like we've gotten a good sense of how she's responding. Nitrous is given by inhalation, as I've talked about, mask or mouthpiece. We really do prefer the mask, feel like it's just a lot easier for patients to get the hang of. There's no time limit. Patients can use it from when they're 1 centimeter or half a centimeter until they're fully delivered. So we typically, the average length of time is probably around 3 hours intermittently. We have some people, again, who use it for, much longer than that, and some who will just use it for maybe 30 minutes and then say, nope, this isn't going to cut it for me. We do try to have them spend enough time with it to know whether this really is working. It can take a few contractions to get the hang of it. So we do try, if somebody has indicated that they want to use it, we do try to give them, have them give it a chance. But some people are just really committed to moving on to other options, and if that's the case, then we support them with that. And absolutely, we use this with hydrotherapy. We have our patients, we have 2 large tubs that the patients hang out in quite a bit, and they can use, the only thing we've ever had happen in the tub is somebody dropped their mask in the tub, and we just changed out the tubing and it was fine, but it was, most people find the 2 work together really well.
Elizabeth, we do have another question. The next question is, when can a patient who has been using nitrous get IV narcotics, i.e., do you have a length of time after stopping nitrous?
Yeah, we do. And I'm just, to make sure I don't say this wrong, make sure I have my policy here in front of me.
Okay.
So I'm reading this directly from my policy. Additional pain medication may be used if desired as follows. Administration of opioids must be discontinued at least 2 hours prior to implementation of nitrous. Opioid medication may be given 5 minutes after the last documented inhalation of nitrous. So it depends on which direction they're going, but I think the question was if they are using nitrous and then want IV medicine, they need to wait 5 minutes, which, we were like, it would take that long to get it scanned and drawn up. And so we would just, if somebody said, I don't want to use nitrous anymore, I want to try Nubane, we would just take nitrous away from them and then document the time of the last inhalation, and that needs to be 5 minutes prior to administration of IV medicine.
Perfect. Yep, I think that's exactly what they were asking. So thank you.
Okay, sure. Good thing I had my policy handy. Okay, so let's see, where was I here? So I think we already talked about rapid onset, rapidly eliminated through exhalation. So if somebody is really not liking how they're feeling, we'll just have them take the mask off their face, take a few big deep breaths of room air, and they're not feeling the effects of it anymore. Because this is patient administered, this is self-administered, the patient has to hold the mask herself. I'm saying mask, it can be mouthpiece as well. They are not allowed to rig it in any way so it will stay on their face. It's really intended to be sort of self-limiting. So if a patient is holding the nitrous to their mouth and to their face, and they're breathing in and out continuously, and they start to feel sleepy, the mask will fall away from their face. So I've had a few women, who are on their hands and knees, and they'll sort of wedge their elbows, under their body, and then the mask doesn't, if they get too sleepy, their face would be more likely to fall into the mask than the mask falling away. So we, you know, at that point, usually the nurses are in the room. They're one-on-one nursing at that point, typically. And that's part of the education, is that you know, this is intended to be intermittent. And the patients, we've never had a problem with it, really. I've never had anybody get so sedated that they were hard to arouse. Definitely have seen people hold the mask on their face until they get sleepy. Their hand falls away, the mask falls away, they breathe some room air, and then they're back at it. They are intended to also exhale into the mask. That's part of how the nitrous is scavenged out of the room air. I think I've already talked about some of this. They're not bed bound. We do consider them technically a falls risk, so we have a very active, ambitious falls committee at this hospital, and use of nitrous does put them up into a higher fall risk. But again, I'm happy to report we have never had a fall. A lot of questions around occupational risk. We do badge monitoring of the environment. Our policy here is about every 6 months. I think we actually did it a little sooner than 6 months. We have always had much further, much lower levels than what is acceptable. I'm going to probably let Lisa answer specific questions, because this starts to tread into a little bit of area that I do less with. I can tell you that the badges are not that expensive. I think they're about $30 a piece. I know some hospitals have their bioengineering group or their facilities group manage that whole aspect of it, but here at this hospital, we will put the badge on the nurse who's taking care of a patient with nitrous. They need to wear the badge for 8 hours, and it just goes in and out of the room with them. We do a lot of one-on-one nursing with our patients, so I would argue that our nurses are probably exposed to more potential exhaled nitrous than some, and we've never had a problem. We mail the badges away to a company. They send back the results of it, and you know, I guess knock on wood, we so far have been way below what is acceptable. I think the people who have been challenged with this have found that there is potentially inadequate scavenging in the room. The equipment, the Pro-Nox machine will hook up to your wall suction, and the nitrous is getting exhaled into the mask and sucked out through the machine and then out through the wall suction that's set up in the med gas system of the hospital. So it's again, we've never had a problem with it. I don't know that if you're using this equipment adequately and you don't have, everything's working the way it's supposed to work, then it's hard to know how you would have a problem with this. But certainly I can't speak to other people's experiences.
Well, Elizabeth, go back and stay on that for a minute, because we got a couple questions. So I knew this would be a hot button, so this is great. The first question was, do patients ever have trouble exhaling consistently into the mask?
Less with the mask than the mouthpiece. So that's part of why we're with them until they really get the hang of it. The mouthpiece, I feel like, is much harder to blow. It's kind of like an incentive spirometer. Like, it's the blowing. You have to keep your lips in a certain position. You have to really make sure your mouth is tight on it. And I think it's harder for people to blow it out into the mouthpiece than it is the mask. We have a large face mask. So the patients will just leave it on their face, take a big breath in, and then exhale through it. I really have not, if they pull the mask away and exhale into the room, we're right on them. We're like, you really need to exhale into this. We give them the education. Why do you need to, why is that so important that you're doing it accurately? And if somebody's like really not getting the hang of it, I mean, I think we've even said to somebody, look, you're going to have to exhale into this mask or you're not going to be a candidate for using it. And that usually solves the problem. But And again, the amount that gets exhaled out into the room is still, it's so, the levels are so low that, I mean, I'd like to say that our patients are probably, you know, perfect exhalers, but probably they're not.
I love it.
And our levels are always, you know, minuscule.
Well,
So,
and I can respond a little bit more to that as well. I mean, the nitrous oxide badges that can be purchased. You do get a free badge with each system that you buy as well, because we encourage you to take a reading. We'd like you to take a reading when you first set up your system, because we want to make sure that everything's hooked up right. Elizabeth talked about the wall suction, and that is a big piece of it, to make sure that your wall suction is functioning properly. We did have a hospital that we found out after doing some testing that their wall suction was not operating correctly in a certain room. So it brought up a few questions about that and concerns, and we were able to help them isolate that and fix it. The NIOSH recommends a 25 ppm or less. And then, of course, there's another group, the ACGIH, which is the American Conference of Government Industrial Hygienists. They say that it needs to be 50 ppm or less. We really default to the NIOSH, and the vast majority of the hospitals that are using the Pro-Nox are testing when they start and then about every 6 months, because that was another question, how often do they do it? And then one of the other questions was, do the nurses always wear a badge when caring for a patient on nitrous? It's just periodic that happens. Some hospital policies do it every 3 months. I've seen every 6 months, and I've seen policies with every year. So it kind of defaults to your biomed and how your facilities group wants to handle that. We would recommend at least every 6 months, just to make sure your system's in check, because things happen. I mean, maybe it got pulled away from the wall. Maybe the scavenger isn't hooked up correctly. So and then the other big one, of course, is exhaling into the mask. Elizabeth hit that one on key. And I think it takes a little bit of rhythm with the birthing mother to get them in the rhythm to breathe in, hold it, and then exhale into the mask before their hand moves away. And then, do the nitrous masks stink like oxygen masks? I like that question. I don't think they do. I don't know what an oxygen mask smells like.
yeah, it's not as, it's the padded like anesthesia masks that they're using. So it is different than the, you know, you're not pinching it around a nose. It's not form-fitting like an oxygen mask. So I'm not sure I ever have put one on my face, but it's not exactly the same. So, and because it's intermittently, I haven't had anybody complain about it. Okay. And if they don't like it, they just disassociate from it. So.
And that's all the questions so far. Sorry about that. Go ahead.
Okay. All right. So our program here is entirely nurse-led. So we have a standing order for every labor patient. The evaluation, consent, and education is provided by an RN. We do document, we have a nitrous tab in our documentation. We use McKesson. We are about to use Ovix, so they'll be built into that as well. Time initiated, what the patient's initial response is. We go through this whole checklist, which I'm happy to share. Anesthesia was involved in the implementation of the program. They were involved in our policy writing, but they are not involved at all in the administration of it. Because it's a gas that they use in the operating room, we felt like they were a great resource for us. But because nitrous, given it this 50-50 blend, is not considered anesthesia, we felt like it wasn't appropriate for them or necessary for them to be involved in the implementation of this program. They are very supportive of this. They are happy that there is an option available to women who come in and are very active and look, really eager to receive an epidural. This allows them to have something that's not narcotic, but something that they can sort of bridge them until they get their epidural in place. I'm sure I don't have to tell people who are on this call, but you know, it's not, if you don't have a policy where everybody gets an IV on admission, somebody who has no IV and who's requesting an epidural right now, it's not going to happen right now. So, but I can set up nitrous pretty darn fast, and we have used it in that way quite a bit. We have also used it for retained placentas, difficult repairs. I've had people who have had, who are not tolerating exams. We'll pull it out and use it with them to great effect. So anesthesia not involved in the program is usually something that gets lots of questions. People that are working in teaching hospitals have expressed concern about anesthesia residents getting their experiences. I'll give you some statistics at the end, but we have not found that nitrous has drastically reduced our epidural use. What it has done is delayed the administration, or the request, I should say, is more appropriate. So women are getting epidurals later in their labor process, and clearly there's a benefit to reducing the risks that are inherent to epidurals. So we can talk more about anesthesia at the end if you've got questions about it, but I know that has been something that comes up quite a bit. Staff education, so we luckily had very eager and engaged staff here who were very grateful to have another tool in the toolbox. It's not hard to learn. It's not hard to learn about. It's not hard to set the machine up. I have gotten a couple questions from people who work in union hospitals, and there's some discussion about, you know, does this fall into, you know, asking the nurses to do something that is not contractually in their, you know, in their agreement. I certainly would not claim to know the ins and outs of everybody's contract agreements, but I can tell you that the administration of nitrous is really not any more complex than giving somebody an injection or IV medication, in my humble opinion. There was an A1 article, there is an A1 article and quiz that accompanied it. I understand that the online quiz is no longer available. I just learned that not too long ago. So what we did, or what was working when we rolled this out, was there was an article that you could read, and then you go online, fill out the quiz, and you were able to print your results, and we use that as part of the competency. Recreating the quiz or doing a paper version of it, I don't think would be very difficult. We have new employees that we are needing to do that with, so I will probably be drafting a paper quiz. Certainly we have a hands-on competency that we roll a nitrous machine into a room with no tubing attached, no nothing, and have the staff nurses prove that they know how to turn it on. There's really no way to exactly test that it's it's right because of the way that the mask works. Until you take a big breath in of it, you don't know if you're going to get any alarms, but we have a checklist of things that they need to go through to know, and then we're available to troubleshoot when they use it with a real patient. We will role play the education. We do some asking, you know, well, what if I, you know, am moving position, can my husband hold the mask? And the answer to that is no. So we really want our nurses to feel comfortable fielding the most common questions that come through. And we have been doing it long enough now that we do have an annual competency. That competency is to review and initial the policy and to do the hands-on competency with a quote-unquote super user. So many unexpected challenges that we faced here, I know are different than what other people have faced or what I've heard. The involvement of our hospital insurance carrier was very unexpected for us. We had full buy-in from our, CMO, CNO, chief of anesthesia, chief of OB. Risk management was kept apprised to what we were doing, and they let our insurance carrier know what we were doing, and they got very involved and caught us all a little bit off guard. We didn't anticipate that. There was a lot of information shared back and forth. I spent hours discussing the evidence around nitrous use. In the end, I'm happy to report we were obviously we were successful. The insurance carrier did not have another hospital in their network that they covered who was using it, and they actually asked if we would be willing to present at, I think it's coming up this fall, a risk management conference. So I'm not exactly sure how that'll go, but I'm happy to, if I can support anybody else who has this this concern. I mean, certainly we were just really, really adamant that, and we kept coming back to, if the evidence does not support the intervention, you don't do it. If there's no evidence that can support the insertion of an IV when it comes to nitrous oxide. If you want to insert an IV for a different reason, that's fine, but we're not going to hang it on the hat of nitrous because it just doesn't belong there. It's not an intervention that is associated with that, and it's just, in my opinion, no intervention should be implemented without being able to rationalize why you're doing it. And, although it's fairly benign to put an IV in somebody, if you're a patient who has a complication of that or is terrified of needles, it's hard for me, it would be hard for me as a bedside nurse to say, well, you need to have this IV because there's no evidence that supports it when it comes to nitrous. So the personal preferences of an MD or of a nurse should not be part of what is written into the policy. So we really worked hard to live by that. It was not always easy. Second big challenge is billing. I'd like to say we have figured this out, but we have not. Some hospitals will work through their anesthesia department. They'll have anesthesia involved in the consenting and education because I think they can bill for it in some way, because we felt like that was not going to be a part of our program. It wasn't appropriate for us to bill through them because they really weren't involved in it. We bill for our supplies. They're cheap. Nitrous is really cheap to administer, so it's not costing the hospital a lot of money. The return on the investment is our patient satisfaction, and a few patients have come to us versus our local competitor because we can offer this where they can't. I think there's some resistance to the fact that it's just new and unknown to a lot of hospitals in this country. And I don't mean to be glib, but it's not really new. It's just kind of renew. So going back into the evidence and looking at what the rest of the world is doing, we're certainly not reinventing the wheel here. This is just being re-implemented as an option for women in the U.S.
Elizabeth, while you're on there, one other thing came up about billing. You did mention that you're billing for supplies. Do you have billing codes that you can share with people that you're billing for that under, and is it getting reimbursed by the insurance carriers?
I'm happy to share whatever I have, and I'm not totally sure if it's being reimbursed. I was very focused on the billing aspect of this for a while. I was just adamant that I didn't care if we got 75 cents back. I just wanted it to not be an unreimbursed offering. To be honest with you, I'd have to circle back with our finance people to find out if we actually see reimbursement. I feel like in OB, we bill for, you can bill, and what you actually get paid for seems to vary greatly. So I'm happy to has that as a takeaway and see if I can answer that question. I know that there is a hospital in the northern part of New Hampshire who is billing a flat rate for nitrous. I don't know the dollar amount. I want to say maybe $300, something not extraordinary. And that captures, their supplies and their gas usage. And I'm not totally sure if they're seeing actual reimbursement on that. Certainly I would argue that they should be, but again, I can't completely close that loop for you, unfortunately.
And I can share with everyone that we're in touch with Michelle Collins over at Vanderbilt. She's leading a group that is working on billing codes for nitrous. She's been doing it for quite a while. And as we get additional information from her, we'll certainly share it with everyone. So there is a big push to get actual billing codes that would make it easier on everyone. We're just not there yet.
Yeah.
One other question, Elizabeth, that came up is, can we get access to the A1 article and the quiz?
I definitely have a hard copy of the A1 article. I have some contacts in A1 that I could probably see if they could release the quiz to us. I don't know I think it was dynamic, so you couldn't, you clicked on it and it brought you to the next thing. Let me see if I can circle back on that. I think the reason that they printed a little certificate is because you got a CE for it. But certainly, I don't know why they couldn't just release the content to us unless there's some contract situation that I'm not aware of.
Okay.
But it was great, and it wouldn't be hugely difficult to reinvent that based on the article. If you took, I think my approach is going to be to take my policy and draft a 10-question quiz based on what I think the 10 really pertinent things in our policy. Like, if you know nothing else, you have to know these 10 things, and then just turn those into quiz questions. So I'm happy to share that. It's on my to-do list.
Okay, wonderful. Thank you.
Okay. And then I left room for questions. I know we've been answering them along the way here. I do have some statistics I'm happy to share, but we can stop here and just answer more questions if you want.
Well, we are up to date on questions, but I'm going to put one more poll out there. Everybody, here comes another poll. I know you've been answering them as we go. The poll right now I put up is, have you already implemented nitrous at your hospital? It's a yes or no. And everybody is voting. And so far it's 100% no. So we've got, that's good. So this, hopefully this is great information for everybody. It looks like everybody that's on the call pretty much has not implemented. And I did a couple earlier polls. Let me pull up the earlier one here. Give me just 1 second. I did ask earlier, Elizabeth, if they had a nitrous policy. 67% of the people on the phone do not. So they had asked, can they get a copy of yours? And I think that's wonderful that you'll share. And then another question was, I asked, will this be a nurse-led initiative when you were talking about how you do it at your hospital? And the overwhelming answer was yes. There were a couple that said no, but 80% said yes.
Excellent.
So those are some of the things that have been coming up. We've answered, I don't know how many questions along the way. So a lot of questions. Why don't you go ahead and share your stats, and maybe that'll close us out and ask a few more questions.
Okay. So it's tricky. I get asked a lot, has nitrous decreased your rate of cesarean sections? Has it decreased your epidural rate? I think the questions come from a place of, can I use nitrous can I sell this as a patient safety initiative in terms of it improving our quality outcomes? And although I completely and totally understand wanting to have any other sort of selling points to your stakeholders, I think that for us, what we have found is, again, I said this already once, that your epidurals are being placed much later. They are being placed probably a little easier. So if somebody has waited and they're very, very active, that nitrous will help with the positioning and the placement of the patient. We certainly have seen, when we first launched, I think the first 3 months of data, we had over 60% of our patients using nitrous. Now, I'm not sure, that could have been some overzealous nursing staff who were really like, oh, everybody has to try this, So I think that, now what we see is much closer to around 30%. Hopefully this pie chart makes sense to people. I thought it was important to show the combinations, because the intention of nitrous specifically, for us, was not to eliminate epidurals or narcotics, but it was just to add another offering to our patients. So you can see that 10% of the people who chose to use nitrous used it alone. They never went on to anything else. Anecdotally, I can tell you probably half of those people thought they would. Believed, well, I'll try nitrous, and then, if I need to change, I will, and never found that they needed to move on to an epidural or something different. Some people just run out of time. They use nitrous with such good effect that, they may be, 8-9 centimeters and screaming for an epidural, and, by the time we can actually get it executed, they've delivered their baby. So now for the patients who are really, really committed to having an epidural, come in stating that that's part of their birth plan, they are going to feel disappointed if they don't have one. We will go ahead and get their IV and get a bolus initiated. They can be using nitrous during all of that, but we won't, if they're really, really wanting one, we'll try to make everything as seamless as possible. Sometimes, it happens, sometimes it doesn't. So we've got 9.1% of the people using nitrous and narcotics. It's typically they will use narcotics first. They'll have a shot of Nubain, and then when that starts to wear off, and then they may be wanting another dose of narcotics, we may suggest to them that they could try nitrous. That needs to be 2 hours after the administration of narcotics, but that's typically the direction. We don't see a lot of nitrous first, then narcotics. It's normally narcotics and nitrous. And then the people who do it all, it's a smaller amount, 5.1%, and then 8.3% of the people are converting from nitrous to an epidural, not the other way around.
That's wonderful information. And one question did come up. We've got a couple questions coming in now. What's the total number for 2014? How many births are these stats over?
Oh, good question. Yeah, I know that. I actually that was on my key. My key got left off. 1 second. So we have a small birth volume here. So let's see. The total number of, so is the question the total number of people who have used it, or is it total number?
What's the total number of births? Yeah.
Okay. So the total number of births that these percentages would be represented from is 451.
Okay, excellent. And then the next question was, would you encourage nitrous as opposed to narcotics? It's a good question.
I'm sorry, you broke up just for a second. What was the question?
Would you encourage nitrous as opposed to narcotics?
I would. I personally would. Unless somebody was using nitrous and it was not working for them. I think that the self-administration of nitrous is a huge benefit to patients. I know when I was a staff nurse, I would give you know, you can give a narcotic to somebody and they may hate the way they feel, and there's not a lot you can do about it. You just have to sort of wait it out. I think patients are less sedated with nitrous. So I've had some patients that I've given Nubain to and felt like I got to be careful they don't slip under the water, you know. So I don't find, I've not seen the level of sedation with nitrous as I have, you know, specifically with either Stadol or Nubain.
I'm just typing your answer.
Yeah, so I think that mostly what it comes down to is the flexibility of it. So if it's not working, you can move on. You're not committed. If it is working, then great. It's dose dependent, so she can take a huge breath in and get a little bit more effect or more shot. It's just the control that it gives the patient is something that, as a nurse, I've seen people just really be happy about that.
I think that's good. Any other last questions for Elizabeth? You guys have been great, very active audience with questions coming in. I love it.
Yeah, great. Thank you.
A couple things. I have recorded this session, and I'm going to figure out how to make it available afterwards. And I want to thank everyone for attending, and especially thank Elizabeth for taking the time to share with you. She really is a great advocate of nitrous and a wealth of information. So after this conference, there's going to be a survey come out. Let us know how we can further help you. And if there's any other questions or concerns, please let us know. Some emails are coming in now, Elizabeth. They're all thanking you. They said excellent. So kudos for your time today. Excellent job.
Thank you.
All right. Thank you, everyone. Look for the survey. As soon as I hit the exit button, you're going to get a survey, and we'll follow up with you. Thank you so much, and have a wonderful week.
Thank you, Lisa.
Thank you.
That was awesome.
Elizabeth, you may have to, hang on. Let me pull it back. Yeah, you're still there, Elizabeth, aren't you?
Yeah, I'm here.
I just got to pull this back to be able to.
Elizabeth, this is